TJ is a 19-year-old male with a past medical history significant for GERD and a prior left inguinal hernia repair who presents to the emergency department with a chief complaint of abdominal pain for 3 days. Pain began around the umbilical region and migrated to the right lower quadrant. Pain has progressively worsened from a 6 out of 10 and is now excruciating in the right lower quadrant. Pain is mostly dull, but will go to sharp and 10 out of 10 above the right hip. Pain has been accompanied by fever, anorexia, malaise, nausea, and non-bilious, non-bloody emesis over the past 24 hours. Patient is now just dry heaving and unable to take in foods and fluids PO since this morning. Last bowel movement was yesterday. He is passing flatus. Past medical history is significant for a patient being on omeprazole PO PRN for GERD and lisdexamphetamine PO daily for ADHD. He had an open indirect inguinal hernia repair at age 14 on the left with no complications. TJ is allergic to amoxicillin, which produces anaphylaxis. He has no relevant family history. He drinks socially and occasionally smokes marijuana. He's a half a pack per day smoker for 3 years, attends community college and lives with parents in Cranston, Rhode Island. He denies cough, sputum production, shortness of breath, and wheezing. His abdominal symptoms are as previously stated. He also denies heartburn, diarrhea, black and tarry stool, and no bright red blood per rectum. He also has no change in urinary habitus or quality. Physical exam, vital signs, T-Kern is 101.0 Fahrenheit, T-Max 101.0, heart rate 112, blood pressure 109/46, respiratory rate 18, pulse ox 99% on room air. He's taken in 1 liter IV normal saline and has had no urine output. In general, he's well-developed, well-nourished young man in mild distress, occasionally dry heaving and into an emesis bin, sclera are non-icteric, dry mucous membranes. Lungs are clear to auscultation throughout without wheezes, crackles, or rubs. Regular rate and rhythm, normal S1, S2, no murmurs, rubs, gallops, or clicks. Abdomen is soft, scaphoid, non-distended, 4 centimeter, well-healed scar in the left inguinal area, no inguinal lymphadenopathy, diminished bowel sounds, percussion is resonant. Liver span is 7 centimeters, voluntary guarding with extreme tenderness to palpation, that is maximal in the right lower quadrant. Positive psoas sign, negative Ross Vangs and obturator signs, no gross blood or purulent material on rectal exam. Genitals show no gross deformities, no swelling of the scrotum, no testicular epididymal tenderness to palpation. Patient has no CDA tenderness. In terms of labs, the BMP today demonstrates slightly elevated creatinine and BUN, 1.2 and 40 respectively, up from a previous admission for hernia repair. CBC is also notable for a white count of 13,000. LFT is notably within normal limits. In summary, TJ is a 19-year-old male with migrating right lower quadrant pain, voluntary guarding, a positive psoas sign, vomiting, fever, and poor PO intake, most consistent with appendicitis. Symptoms have been going on long enough now that the patient is at risk for perforation, but the lack of peritoneal signs at this time speak against that. Shrinkle reherniation unlikely given that his prior surgery was on the left side. Small bowel obstruction secondary to post-surgical adhesions, Meckel's diverticulitis, and perforation secondary to other infection or inflammatory bowel disease are also on the differential at this time. GU causes such as UTI, pyelonephritis, and testicular torsion are far less likely based on the history and physical. Plan is to treat tachycardia and vomiting with IV fluids and antiemetics, pain control with IV Dilaudid, obtain abdominal CT, NPO for now, and consent for a laparoscopic appendectomy pending the CT, administer ciprofloxacin and metronidazole IV for gut flora coverage, and will avoid penicillins and cephalosporins due to history of anaphylaxis.